happy to have Laura Bonouvrié today with us, and she has a training in rehabilitation medicine at the Amsterdam University Medical Center, obtained there, and a PhD, which she has obtained in October 2019 on intrathecal baclofen treatment in children with neurological disorders. And her current position is pediatric physiatrist at the same institution. Her focus is on complex care for cerebral palsy and on spasticity and dystonia. She is network member of the European Dyskinetic CP network, of the Dutch group on movement disorders in children, and of the Center of Expertise for Cerebral Palsy. So thank you for accepting the invitation, Laura. We are very happy to have an engaged child rehabilitation doctor today, working in interdisciplinary team and focusing on the children, on the individual. So thank you, and I will stop sharing my screen so that you can start with yours.
Yes. I think this should be the right one. There. You should now be able to see my screen, I hope, because I see it differently, so I'm not sure what you're seeing. I hope it's the right one. Thank you for the invitation to present something about my my study today. And let's see if this is going to the next slide. Yes, well, this is what you already explained, everyone. And what I wanted to know before I continue is to know a bit more about who's listening today. And Sonia made a poll for that. So I hope everyone can write their professional background. I'll give you a few moments to do so.
So already 70% now have already voted or given their professional background. We will wait another 10 seconds and we will close the poll. Okay,
So most people listening are neurologists, 43%, neuropediatricians, one physiatrist, who's I think my colleague. There's some residents and physiotherapists, a nurse, 3 nurses, and 2 researchers. Okay, thank you. The learning objectives for today is that by the end of this webinar, you'll be able to know the definition of dyskinesia that we use for cerebral palsy patients, understand the hazards of RCTs in rare disease, and identify patients with dystonia who might benefit from intrathecal baclofen treatment. I will do this by giving you some background information and definitions, and then I'll tell you a lot about the trial we conducted, how we did this, how we plan to do it, and how reality also hit us on this matter. And I'll show you the results and the conclusion, of course, and a little glance into the future. Everybody probably knows, just briefly, I'll explain a bit about cerebral palsy. We use cerebral palsy as a blanket term for a neurological disorder that is caused by a non-progressive brain injury or malformation that occurs while the child's brain is under development during pregnancy, birth, or the first year after birth. And cerebral palsy primarily affects motor function. However, other problems can occur as well. And the movement disorders that we see in cerebral palsy are divided in spastic, dyskinetic, and ataxic. And a combination or two, and even sometimes more, is also possible. And cerebral palsy itself is not a rare disease. It occurs in 2 per 1,000 live births, and it's actually the most common cause for physical impairment in childhood. However, the dyskinetic type of CP occurs in 15% of the CP patients, which are 3 children per 10,000 live births. So that's a little bit rarer than the cerebral palsy altogether. And in cerebral palsy, we also divide the dyskinetic form even further in dystonia and chorioathetosis. This is a figure made by a colleague from Leuven, Eligas Montbalieu. And he, in this figure, shows patients with dyskinetic cerebral palsy, and each bar represents one patient. And in dark blue, you can see the part of dystonia in one patient, and in white, the part of chorioathetosis. And what you can see is that both occur frequently occur simultaneously in the same patient. However, dystonia is mostly the most dominant feature for these patients. A couple of definitions, because I know that in the world of neurology, definitions sometimes vary. So this is what I'll be using for my presentation today. Dyskinesia in cerebral palsy is defined as involuntary, uncontrolled, and recurring and stereotyped movements with varying muscle tone. And as I said, it can be further divided into dystonia and chorioathetosis. And dystonia is defined as involuntary movements or intermittent muscle contractions that cause abnormal movements, such as twisting or repetitive movements, or abnormal posture. And you can see it in this patient in many body parts. But you can see it in his right arm, which is all the time in a flexed position. And you can see it also in his big toe, which is upward, facing upward all the time. And he also has a lot of movements in his face, but you can't see the face in this video. And then chorioathetosis is defined as more ongoing and constantly changing involuntary movements, which you can see in this girl in her mouth region. You can see that it's moving all the time. It doesn't really go to an end posture, but it keeps on moving. Most patients with dyskinetic cerebral palsy are severely affected. About 80% are classified in the gross motor function classification system level 4 and 5. This is a classification system we use for gross motor function. Level 1 patients have almost no problems, and level 5 and 4 also patients are dependent on a wheelchair for mobilization. And most patients are classified in the highest level 4 and 5, making them dependent on a wheelchair. And in this group of patients, the treatment goals are usually on improvement of caregiving, improvement of transfers and sitting, and improvement of comfort and pain, and also prevention of contractures. And I have another question for you that Tanya put in a poll. And that is, which treatment options for severe dystonia do you use in your clinical work? And there's multiple answers possible for this question.
Okay, we will give you 10 seconds more to respond to this question. Okay. So here are the results.
Oh, the results. So many of you use oral medication, also a great part botulinum toxin, the brain stimulation and intrathecal baclofen, a little less orthopedic surgery, on muscles and bones are also used, but less frequently. As well as a paper also written by Eligas-Montbalieu in 2017 in the Lancet Neurology, and also a paper by Feelings et al. In 2018 described the treatment options for dystonia and cerebral palsy. And the AAC-PDM, they published a care pathway for treatment of dystonia, in which I hope you can see it. Oral medication over here is the first choice in generalized dystonia. And recommendations on which drug to use are based mostly on expert opinion, not on scientific evidence. Then the next step, once dystonia is more severe and oral medication is not efficient enough, could be ITB, intrathecal baclofen treatment, or DBS, deep brain stimulation. They're both yellow, and yellow means that they are probably or possibly effective. And then the results of intrathecal baclofen in patients with cerebral palsy are a little bit more consistent than the results with deep brain stimulation. Intrathecal baclofen treatment is a treatment option in our center. A pump which is the size of a shoe polish tin, it's in the middle of this slide, but it's pretty big, is implanted under the skin in the lower abdomen. A catheter then connects the pump to the intrathecal space around the spinal cord where the baclofen is delivered. And for dystonia, we put the catheter tip on the level of C4, so quite high. This pump has to be refilled every 3 to 6 months by a puncture through the skin, and the battery lasts for about 7 years, and then the pump needs to be replaced. The most frequent complications seen are cerebrospinal fluid leak shortly after surgery, infection, which usually occurs 2 to 4 weeks after surgery, and catheter-related problems, which can also occur in the long term. And the last problem, the catheter problems, can cause a sudden stop of baclofen delivery, resulting in withdrawal symptoms, which can be very severe, even so severe that death can be a consequence if they stay unrecognized. ITB seems to be an effective treatment option for spasticity. However, there were only a few studies on the effect of patients with dyskinetic cerebral palsy. There were few, and the quality was also quite low, mostly case reports. And for that reason, we conducted the IDIS trial in the Amsterdam UMC and also the Maastricht UMC, both in the Netherlands. And I'll tell you a bit more about this study. The aim was to provide evidence for the effect of ITB on individual treatment goals, and secondary also for the effect on dystonia, spasticity, range of motion, pain, comfort, and treatment-related complications. Patients who were between 4 and 25 years old with the dyskinetic form of CP and the GMFCS level 4 or 5, so they had to be wheelchair dependent on a wheelchair for mobilization, who also had lesions on their MRI explaining the dyskinesia, were included in our study if they were eligible for ITB. And in this video you see a patient, yes, it works, who is a typical example of patients that were included in our trial. So the patients were really severely affected. The criteria for ITB is that the etiology is preferably known. That is not always possible, so it's preferably we first manage aggravating factors such as pain of discomfort before going to a baclofen pump, and also other treatment options such as oral medication should have been explored. The movement disorder a patient has should be so severe that it interferes with activities of daily life or quality of life, and the goals have to be clear so that patients know what to expect and we avoid disappointment, because it's a pretty big step to have a pump implanted. So we want to be clear what we expect. People have to be motivated because there are requirements to treatment, and the patient has to be big enough to have a pump implanted. Well, as I said before, we conducted a trial in Amsterdam and Maastricht. It was a multi-center randomized double-blind placebo-controlled trial. And we, after patients were assessed for eligibility and included in our study, they were randomized into 2 groups, the placebo group or the ITB group. And both groups received blinded treatment for 3 months, after which the measurements were repeated. Finally, we included 18 patients per group. And due to severe illness of 1 patient in the ITB group, only 17 patients had a pump implanted in this group. And although 17 patients were analyzed, and 16 in the placebo group, 2 had complications and didn't have a pump anymore when we did analysis. We started this trial in, or actually the planning of the trial, November 2009, by writing the protocol and getting all the funding and the medical ethical committee approval. And the first inclusion was in January 2013. And we aimed to include 30 patients over a period of 2.5 years. And when we started the trial, the patients had the choice whether to participate or not, because we were already offering this treatment before, mostly for patients with spasticity. Well, as I said, they had the choice, and that was a problem for our trial. Because after 1 year, we only included 4 patients and we needed 30. And that's when the Data Safety Monitoring Board and also the Medical Ethical Committee stepped in and said the intrathecal baclofen for dystonia is an experimental treatment, so we're going to do this only in trial, in the trial. And we also extended the inclusion period for the first time. We had some more problems, complications occurred, and we didn't know in which group, of course, they occurred. And that's for that reason we decided to include more patients. We started with 30 and eventually included 36 patients and extended the inclusion period a couple of times until we finally did our last measurements in July 2018. So instead of 2.5 years, it took us 5.5 years to include enough patients in our trial. So what did we do for outcome measures? Our primary outcome measure was goal attainment scaling. And in goal attainment scaling, 2 or 3 individual treatment goals are set prior to starting the trial. And these goals were evaluated after 3 months of blinded treatment. And with the scores of the separate goals, a standardized score can be calculated, and that score can be used for statistics. And this is an example of a goal attainment scale in which, for this person, the minutes someone can sit in a wheelchair are scored. The score always starts with a baseline score, the situation at the moment you make this table. And that's all. The baseline is also, if you repeat the score after 3 months, is if there's no change, you keep the score of -2 for that goal. The aimed goal is always a score of 0. That's when your goal is achieved. It is also possible that you don't achieve a goal, but that you do improve on the goal, and that would be a score of -1, or you can achieve more than your goal, which could be +1 or +2. And the last option is that someone worsens, and there's also a score for that. We included several secondary outcome measures for dystonia, spasticity, range of motion, comfort, pain, and adverse events. And I will show you a bit more about the outcomes that we used for dystonia. We used the Berry-All by Dystonia scale, which is a scale to score secondary dystonia, such as due to cerebral palsy. And for this scale, dystonia is scored in 8 body regions on a 5-point scale, ranging from none to severe. And the total score ranges from 0 to 32. We also used the dyskinesia impairment scale, which is a newer scale to score dystonia and also choreoathetosis. It scores both in 12 body regions, as well during rest situations as during activity. And you give a score for duration of the movement disorder and the amplitude on a 5-point scale. And eventually you get a total score which ranges from 0 to 100%. And the score can be calculated separately for both dystonia and chorioathetosis. In our trial, most individual treatment goals were related to facilitate caregiving, including washing and dressing and hygienic care. Goals for mobility were also frequent and were mostly to improve transfers in sitting, and other goals were to improve comfort, pain, sleep, and communication. We found for the goal attainment scaling a significant difference between two groups in which the ITB group scored better than the placebo group, which is shown in this table. And you can also see it in this figure. I show here the number of goals which are attained on the left, ranging from 0 to 3, 0 in black and 3 in pretty pink. And what we see is in the placebo group that 87% did not achieve any goals, compared to 41% in the ITB group. And when we look on the figure on the right, we can see the number of goals that are at least partially achieved. So maybe not completely achieved, but there is improvement after 3 months of treatment. And what we see is, again, for the placebo group, 87% did not improve on any of the goals, and 12% in the ITB group did not show improvement on any of the goals. For dystonia, we did not find a statistical or clinical significant difference for the bets. They say that a 25% difference on the peri-op dystonia score should be clinical significant, but it was only a very small change and not statistically significant. For the dystonia impairment scale, the difference was statistically significant. However, it was a very small change. The difference was 9%, ranging, or the 95% confidence interval ranging from 16 to 2% change difference. Sorry. So it wasn't. It's significant, but it's not a very big difference. However, it is a difference between groups, and chorioathetosis was not significantly different between groups. Also, on the other secondary outcome measures, we did not find a significant difference between the two groups. So for spasticity, pain, comfort, range of motion, and also the adverse events, they were equal between groups. So with this study, we are the first to provide a level 2 evidence for the effect of ITB in attainment of individual treatment goals in patients with dyskinetic cerebral palsy. And we learned that trials with rare disorders or rare treatment options take a lot of time and effort. And in the future, we want to establish the longer term effects and also know which factors influence outcome for these patients, so we can make maybe even a better selection than what we're already doing. And I think to do so, we need collaborations and networks to conduct larger studies and trials also with a longer follow-up period. This was my presentation. Thank you very much for your time and attention, and also a lot of thanks to my team, of course, and all the funders for the good work that we've been doing together for the past years. And I'm sure there will be some questions.
Yes, please, you can write your questions now in the Q&A box. In the lower toolbar, you can see that tool. So we can wait just a couple of minutes if there are any questions arriving. one could see that the perseverance in those kinds of studies is also very important, Laura, as I could hear that you remain, stick to your aim, although one can encounter some complications. So this is also something happening in real life.
Yes.
Okay, so we have the first question. Just one comment. Yes, I will send the link for the recorded webinar just right now in the chat box, but here in the Q&A, we will address the medical content questions. So the first question is, what can you say about intrathecal baclofen in spasticity in multiple sclerosis?
Well, I work with children, so that's not my field of expertise, but my colleagues who do work with adults and the baclofen pump use this for treatment for treatment of spasticity in multiple sclerosis. We have many patients in our clinic who with MS and a baclofen pump. And I think also here you have to I think it's about the same criteria as we use for the children, that there has to be a problem because of the spasticity, you have to be sure that there's no easier treatment options that help your patient.
Right. Okay. So another question: do you perform any specific test before inserting the baclofen pump?
We do. What we do first to get the indication is that we see the patients with a multidisciplinary team, which, depending on the problem of the patient, always includes a child neurologist, a rehabilitation doctor, and then depending on if they where the problems are, we involve occupational therapy, physiotherapy, and speech and language therapist. And we do the well, they all do their tests on their field of expertise, and then we decide together if someone is eligible for a baclofen pump. And what we also do, which is also a test, is in patients with spasticity. We do a test treatment before inserting the pump. So they get one-time bolus of baclofen intrathecal with a lumbar puncture to see how they respond to the intrathecal baclofen. I don't know if that answers your question.
We may get another feedback from that user or from that attendee. We can, in meanwhile, go to another question. Do you feel able to comment on the relative roles of ITB and deep brain stimulation in secondary dystonia or dystonic CP?
I think we know a little bit more about the effects of ITB in these patients. Also with the trial that we did. There's not a lot known about cerebral palsy and deep brain stimulation. There are some studies which some show positive effect, others show a no effect, others show negative effects. So we're not quite sure yet where the deep brain stimulation stands. And also these patients often have lesions in the basal ganglia, which makes deep brain stimulation not always possible for these patients. But I think it will be a very interesting field of research for the future to find out.
Thank you. Another question: any kinds of different outcomes between ITB and botulinum?
I think the indications are also different. And also the effects. The botulinum you can use for focal treatment. So if there's only a couple of muscles that you need to have more relaxed, then botulinum toxin is a good option. But if the spasticity or the dystonia in this case is so severe, then maybe ITB is a better option.
Mm-hmm. Okay, so which is the main reason for decision to implant baclofen IT pump to treat dystonia and not to implant DBS in case if brain MR is not showing diffuse abnormality?
Yeah, if the MR is completely normal, I think you have to ask yourself first: is this really cerebral palsy or is it something else? If we would have a patient in our clinic with a normal MRI scan and dystonia, we would first do genetic tests to be sure of what we're treating. And then maybe DBS is a better option. That could be possible, and we consult our colleagues who know everything about DBS. Yeah, so I think that should answer the question.
Yeah. Okay, and then a question, I would like to know in which level the ITB is inserted. I think you have mentioned that, but maybe...
Yeah, for the dystonia, we inserted at cervical 4 level.
Yes, that was it. And in which age will be more successful ITB for children with cerebral palsy?
At what age? It depends on the patient. We have patients who we see when they're 3 years old, and you think they could really benefit from ITB, but they're still too small, so it's not possible yet. And we also see patients who are 12 years old who have problems at that moment and need baclofen when they're 12, and when they were 4, everything was still fine. So it really depends on the patient and what age you should consider ITB.
Mm-hmm. Another attendee asks, I wonder what the origin or the brain region of dystonia is in CP children, and if this was taken into account in the study.
Yeah, most of them had basal ganglia lesions in the putamen and globus pallidus. And we did take that into account in the study. We assessed all the MRI scans from all patients and also used it in our analysis. And yeah, that's actually what we did with it.
Mm-hmm. And I think for the moment, the last question. Finally, would you like to recommend ITB? I'm not sure if I understand also the question, but maybe Gilang Nispu can reformulate the question. In the meantime, we can answer another one. According to your experiences, which one is better, baclofen or THP or combination?
I'm not sure what THP.
Can the attendee specify what hides behind this abbreviation? Another one in the meantime. Why do you think that none of your measures found any change, yet you achieved some of your goals? Is it that scales are not sensitive enough, or that they do not measure what is important to the patient?
Yes, that's a very interesting question. I think the scales do measure the dystonia because that's what they were made for. However, the question is the difference big enough to find with these scales? Are these scales sensitive enough? I'm not sure if they are. And also what we see in these patients is that the dystonia or dyskinesia varies throughout the day, throughout the week. and when people are stressed, it gets worse. When you go to a hospital, you're stressed. So maybe in their home situation, if we did the measurements at home, we would have found a difference because they would be more relaxed at home, and it would be really different from before and after ITB treatment. But in the hospital, because of the stress, the dystonia gets worse, and maybe that's why we don't see any difference. So hopefully in the future we'll have maybe other methods of measurement of dystonia that can use us to answer this question.
Mm-hmm. Interesting. Yeah. You commented on test doses in spastic CP. Can you expand on why you do that? If you have a clear history that the spasticity responded to oral baclofen, even if it wasn't good enough response, what do you gain from the test dose?
The effect that you see with oral baclofen or with intrathecal baclofen, it's not comparable at all. So I also saw the question if there's any dose equivalence to oral dose. There's not. It's very different. Also, patients who have many side effects from oral baclofen will probably not have it with intrathecal baclofen. And the test treatment that we do is because we also want patients to, there's multiple reasons. If the patient is walking, you want to be sure that they're still able to stand and walk while having ITB treatment. So that's what we test. We also test if it's, usually in the spastic patients, it will be beneficial and spasticity will decrease, but not everybody is very happy when spasticity actually decreases. So we want patients to experience what it is like to have less spasticity. And you also want to see if there's no, well, let's call it side effects. If, for example, the trunk gets too weak and patients are not able to sit anymore, or what I said before, not able to stand anymore. In some patients, speaking or swallowing gets more difficult, and that's what we want to know before we actually implant a pump, in what way a patient responds.
Mm-hmm. Okay, so there is a question if you may know which countries in Asia can perform ITB?
No, I have no idea.
Okay. Have you found arachnoiditis as a side effect of ITB?
No, I think that is meant that it's a chronic inflammation of some sort. No.
Okay. Can ITB worsen scoliosis?
That's also a very interesting question that I have to leave unanswered. There are also for ITB and the effect on scoliosis are very few studies that are done, and most of them are also of a low quality. There are only a couple of studies who compare a control group with the ITB group, and then some show that scoliosis gets a little bit worse with ITB, and others show that it's the same. And I think that the group of patients that we treat with ITB is a group of patients that are severely affected and are already at a high risk of scoliosis. And they will get it with ITB and without ITB. But there is not a direct link shown between ITB and scoliosis at the moment.
Mm-hmm. Right. Okay. So I think there is another one. If you had the chance to redo your experience, would you do something differently?
No, I don't think so. I think we thought over things very well, and yeah, I think we were all very happy with how things went. It took a little bit longer, and we had some struggles, but eventually it all worked out well. So no, I wouldn't.
Okay, So I think we can conclude on that. Thank you, Laura, for explaining and presenting this interesting study and explaining all the facets of doing that in real life. And hope to see you everybody in our next webinar on July the 9th. So in 1 week time, more or less, and stay safe and goodbye.